I will be talking today about lupus and fibromyalgia. And in terms of lupus, before I go into what is it, it's important to know what causes it. And like Dr. Shibuya talked about before, it's something that you're born with, that you have genes that predispose you to getting lupus, but then you're also exposed to certain environmental triggers, such as medications, being out in the sun, smoking, and this turns on a set of genes, and then that kind of triggers the immune system to react, and then you develop these symptoms. And we do know from genetic studies that there are certain genes on chromosomes 1 and 6 that can predispose someone to getting lupus. 10% of people who have lupus have someone in their family who has already had a diagnosis, and 5% of children who are born to mothers who have lupus end up developing lupus themselves. But there's something more than just the genetics, because in identical twins, for example, only one twin has lupus, the other twin has a 30% chance of developing lupus, which means there's 70% of something out there in the environment that can affect and effectively trigger the immune system. And also there are certain ethnic groups that are also more predisposed to developing lupus. This includes Native Americans, African Americans, Asian Americans, and Hispanics. There are various different types of lupus, and the word lupus is actually from Latin, and it's basically describing the way that the skin appears when you develop a rash in a butterfly distribution on the face. It looks like the skin being mauled by a wolf. There's systemic lupus, which has multiple organ involvement, but there's also types of lupus that are only related to the skin, or cutaneous lupus, neonatal, which occurs in infants, and drug-induced lupus. The systemic form is the most common and also most serious form of lupus, because it can have the potential to affect various different organ systems. However, every patient is unique, and so some people may have a very mild form affecting just the skin and the joints, whereas some people can have kidney involvement, their lungs and their heart may be involved as well. Typical symptoms include a rash that's photosensitive, which means that they get a rash triggered by being out in the sun, and they can also have joint pain, have flu-like symptoms. Oftentimes it can be triggered by pregnancy. There are skin-only forms, and so in these people, even though it's just affecting the skin and it's not life-threatening, it can be quite debilitating, and they can be associated with some antibodies that we can find on blood tests. And then there's another chronic cutaneous form. This one is usually not associated with turning into a more systemic form. Less than 10% of people who have this type of chronic cutaneous lupus develop the more systemic organ involvement. The neonatal form of lupus is a unique type of lupus that's related to the antibodies from the mother that's passed on to the baby. And they have these antibodies called SSA and SSB. So a mother who has these antibodies who may not have lupus, their child being born has a 2% risk of developing this neonatal type of lupus. It's transient, so it's not permanent, but it can still be quite debilitating. The babies can have low blood counts, their liver function tests can be elevated. But usually these symptoms should go away after these antibodies kind of go out of the baby's system after about 6 to 8 weeks. There is one more serious manifestation, which is permanent heart block. And these antibodies kind of attack these conducting cells in the baby's heart, and that can actually cause permanent conduction block. And so then these babies might have to wear pacemakers. But that's typically rare. And even when the child, these antibodies go out of their system and they return to normal, they can still have a chance of developing lupus, about 5% chance of getting lupus later on in life. The drug-induced form of lupus is basically exactly what it sounds like. It's the trigger when patients are exposed to a certain type of drug, and then they develop these antibodies and develop symptoms of lupus, which are usually more mild than the systemic form. Usually fever, having muscle aches, rash, and some inflammation of the lining around the heart and the lungs called serositis. And the antibodies that we check are usually the antihistone antibodies are positive in about 95% of the time. And the treatment is actually quite simple. Just stop the drug, and usually the symptoms should go away after a few weeks to months. But sometimes some symptoms can continue. So these patients may require some medications, anti-inflammatory medicines, and then prednisone if needed. The most common drugs are listed here, but there's hundreds of drugs that may potentially cause drug-induced lupus. So hydralazine is a very common drug used to treat blood pressure. Procainamide is an antiarrhythmic. Isoniazid used to treat tuberculosis. And even the drugs that we use in rheumatology, TNF inhibitors, can sometimes cause drug-induced lupus. These are the typical symptoms, so there are many, and it's ranging from the most common being joint pain, fevers, and rash, all the way down to seizures and having abnormal clotting problems. Again, it's, because it is a multi-system disease that's triggered by your immune system, you can have different manifestations in any organ, and so there's involvement of hair, so people can have hair loss, arthritis in multiple joints, the butterfly-shaped rash, which is over the cheeks and the nasal bridge, and then it can affect the kidneys, so some people can have blood in the blood or protein in the urine. So, this is, some of you may be familiar with House, and he's always saying that it's not lupus. Unfortunately, sometimes it is lupus, but how do we really get to the diagnosis? And it requires a skilled rheumatologist to really get the good clinical picture. There's no absolute blood test that you can check and say, yes, you have lupus, or there's no X-ray or MRI that you can do. So it's really based on a clinical diagnosis. It's based on the medical history that's provided by the patient, but also a very complete and thorough physical exam, and then basic blood testing, just looking at the blood and urine. And sometimes if there's different abnormal tissues, we can biopsy that and look at those tissues and see findings that are consistent with lupus. But it is a very difficult, sometimes difficult disease to diagnose because people come in with a lot of non-specific symptoms, and they may not get a diagnosis until months to years later because it imitates and it mimics a lot of other diseases. So there are classification criteria that were developed in order to try to detect people with these symptoms and make sure that we don't miss people who have lupus. And so they're based on, up here, some findings. Serositis, again, this is basically inflammation around the lining of the body cavities, like around the lungs, the heart, the abdomen. People can have oral or nasal ulcers, and then arthritis here, rashes related to being in the sun. So these are things that you can just, based on the patient history and physical exam, we don't even need a blood test for a lot of those things. But again, blood counts. So this is something that patients may not know about because it's based on a test that you'd have to go to your doctor to find out that you have a low white blood cell count or a low red blood cell count. And then protein in the urine. So that's a marker of inflammation in the kidney, and so that's a test that can be done just by checking a urinalysis. This antibody, the anti-nuclear antibody, is something that I'll talk about later, but it's basically a sign that there's something, your body's reacting to some autoantigens, like to self, proteins, rather than the immune system where it's supposed to attack things that are foreign from the outside, like Dr. Lee was talking about earlier. And then there's also neurologic manifestations, so people can have seizures, they can have psychosis, and then various different types of rashes that we can see in lupus. So in 2012, there's another, the SLIC, which is another organization for lupus, that came up with a different set of criteria that tried to capture more people with lupus. And so it's basically more of the same stuff, but it also includes, if you have a kidney biopsy that shows findings consistent with lupus and just a positive blood test, then that's already enough to satisfy the criteria. You don't need at least 4 out of these criteria. So it's basically to help us diagnose lupus. But this is just to show you that this is really a clinical diagnosis, and it's a set of different criteria, and it's not just one thing that can diagnose it. Other common lupus manifestations that are nonspecific include fevers, malaise, and weight loss. And so these can be seen in a lot of different chronic conditions, including cancer, diabetes. It's very nonspecific, but very common to people with lupus. And Raynaud's phenomenon is something that's quite common as well. It's basically changes in the color of the hands and feet when it's cold outside, related to temperature. The arteries and arterioles kind of spasm down, and so then you have decreased blood flow, and so fingers will turn white, purple. And then there's also a high risk of heart attacks in people who have lupus. And so, inflammation, like Dr. Shibuya was talking about, it has been leading to a lot of chronic diseases. And so it's interesting that young women who have lupus, they have an actually greater than 50-time risk of developing a heart attack than people who don't have lupus of the same age. So it's actually something that we always screen for cardiovascular disease in all of our lupus patients. There's also higher risks of cancer, especially certain types of lymphomas and lung cancer. There's a higher risk for infections because the immune system is dysregulated, but also because of the medicines that we use to treat lupus sometimes suppresses the immune system and puts patients at more risk, unfortunately, of developing infections. There's also higher risks of bone damage, so osteoporosis, which is thinning of the bones, and avascular necrosis, where you have decreased blood flow to the bone, and actually part of that bone kind of dies away. And this happens in the hip and the knees and can cause excruciating pain, which sometimes requires surgery. So the ANA blood test, it stands for anti-nuclear antibody, and it's basically a test that tries to find out if the antibodies in a patient's blood reacts to autoantigens, which are basically self-proteins. And so when the test is positive, it means that the patient has this autoantibody. It's very nonspecific because the antibodies can bind to a various number of self-antigens and can be seen in different autoimmune diseases, not just lupus. So having this positive blood test doesn't always mean that you have lupus. It just means that you have something that may be autoimmune. And so you can see different patterns of binding. And so there's lupus, but also rheumatoid arthritis, systemic sclerosis, and different types of inflammatory muscle diseases that this test can be positive in. And there's also some other lupus lab tests that we monitor, including the complete blood counts, checking the kidney and the liver enzymes, and looking at the urinalysis. There's levels of inflammation, so these tests that we can check called the ESR and CRP help to see how much inflammation is going on in the body. And there's also tests that we can see to see how active the immune system is doing. This is a cover of Time from about 10 years ago, the surprising link between inflammation, heart attacks, cancer, Alzheimer, and other diseases, and what you can do to fight it. So this goes back a lot to what Dr. Shibuya was talking about earlier, and how inflammation is kind of at the heart of everything. It can lead to all of these different chronic diseases, and here we are with the autoimmune diseases in lupus, arthritis, diabetes, just to name a few.
I have a question.
Yes.
When you're on your bioagents and everything,
Mm-hmm.
so your levels are altered from that. When you're still checking for these levels, are you seeing if the bioagent is masking, for lack of better terms, your levels, or?
Right. Okay, so I'm going to repeat the question. So basically, you're asking these bioagents that are affecting the immune system, when we check these tests, would those agents mask the different levels? So actually, it's quite interesting, because in patients who who these levels are dysregulated because of the active lupus, usually the numbers improve because we're actually helping to balance. It's more of like a balance, like the immune system is being more balanced, and so then the blood counts come up, they get better, the inflammation levels actually come down, and then the activities of the immune system, these C3 and C4, which when you have a lot of lupus, the immune system is kind of consuming it, so the numbers drop. All of a sudden on the drugs, these levels come up because they're not being consumed as much. It does get confusing, and that's why it's sometimes medicine is an art. Certain medications can lower the levels of blood counts, and so we really have to weigh it all together with the clinical manifestations. If all of the numbers are going down, but then the lupus is doing great, then maybe it's related to the drug. Whereas if the numbers are going down and the lupus is really active and flaring up, then maybe it's because of the lupus. We need to give you more different drugs to help regulate your immune system better. So it's really more taking in clinical context. So the natural history of lupus is that the majority of people, about 40 to 60%, remain chronically active. So that means that they require medications and medical management to help control the disease. It is a chronic condition. For other people, 25 to 30% can be relapsing and remitting, and then for a minority, about 15 to 20% can have quiescent disease for at least a year. There are various different treatment options, and this section here, this is all, what can you do if you have lupus? And basically it's trying to prevent flares. So being in the sun, it's a big trigger, UV light, affecting the cells of the skin can actually stimulate the immune system and cause lupus flares. And so trying to avoid sun exposure between, light hours, and then wearing protective clothing or wearing sunscreen if you go out in the sun. Also managing stress is very important, making sure to keep your immune system healthy by having regular sleep and exercise. Quitting smoking, because again, that's another trigger that can lead to your immune system being activated. And it's important to have all of their immunizations updated as well, because of the dysregulated immune system, because of medications. People can have an increased risk of getting infections. And there are different educational resources out there. There's a usinlupus.com website and drshibuya.com. Medications, again, this is just for the interest of time. I won't go into all the different medicines, but medicines can range from anti-inflammatory medicines such as ibuprofen or Aleve, prednisone, and then we go up to the stronger immunosuppressants that some of these medicines need to be given IV, but these medicines are really to help kind of control and regulate the immune system. So, and also it's a multidisciplinary approach. So there are multiple different providers that work together to help get a person well. So not only the rheumatologist working with the primary care provider, but involving the family, physical therapist, sometimes other specialists if there's other organ involvement, such as a cardiologist, a nephrologist for the kidneys. So it really is a very well-rounded approach. Here are some more lupus educational resources, Lupus Foundation Northern California.org, and they have a newsletter that you can sign up for. So I kind of went over that pretty quickly, but are there any other questions about lupus before I move on to the next topic? Okay. So kind of switching gears a little bit, this is talking about fibromyalgia. And what is fibromyalgia? Because here we are talking about inflammation and arthritis and autoimmune diseases. Well, fibromyalgia is actually not any of those things. It's not a form of arthritis, but it's something that can occur in patients who have arthritis, who have lupus, and other autoimmune diseases. It's a chronic, widespread muscular pain syndrome of unknown origin that's been going on for longer than 3 months. And it affects about 5% in the US population. It's more common in women and gets increasingly more common with age. And it's often associated with these other functional somatic syndromes, things where people have symptoms where there's no clear physical cause, such as irritable bowel syndrome, migraine headaches, and chronic fatigue. So the typical patient will come in and say, doctor, I hurt everywhere, I have pain all over. It's like, well, is it the joint? Is it the muscle? No, it's everything. Everything hurts. So usually it's worse in the morning and also when it's cold. And people will often complain about having fatigue and very unrestful sleep. When you talk to people with fibromyalgia, they really feel unwell. And it's interesting though, because on physical examination and laboratory testing, everything is normal, except that there's a tender point examination that's positive, where there's certain areas of the body where the physician will press just enough to blanch your fingernail, so that's not a lot of pressure, and that should be experienced as pressure. But people with fibromyalgia will actually feel that as pain. So you can even try it on yourself, just to blanch your fingernail and like push yourself on the chest here. It shouldn't hurt, but it's exquisitely tender and painful in people with fibromyalgia. Basic blood tests will be normal, so the basic blood counts, chemistries looking at the liver and the kidney, inflammatory markers, the muscle enzymes and thyroid tests should all be normal. Like Dr. Shibuya mentioned earlier, arthritis is to the joint as rheumatism is to the body. Fibromyalgia patients really feel as though all of their joints are swollen when in actuality the joints are not swollen, but it feels very swollen. And again, there's very many forms of arthritis. And so fibromyalgia patients can have both fibromyalgia and arthritis at the same time. There's also periarticular pain syndromes. These are the different soft tissue structures that are surrounding the joint that can be a source of pain. So right here, bursitis, it's a fluid-filled sac that kind of helps to cushion your joints. That can get inflamed and cause local pain and swelling. Also, capsular or ligamentous tears hairs like around the joint capsule. If any of those areas are inflamed, that can cause pain. The tendon insertion and the enthesis, so enthesitis, like Dr. Lee talked about earlier, and even the tendon sheath, something surrounding the tendon can also have pain. And so even though this isn't arthritis, it can cause pain around the joint and be perceived as joint pain. And it's very common, especially in people who have overuse syndromes, like you hear about tennis elbow and golfer's elbow, shoulder bursitis. But this is not arthritis, and it's basically just pain related to the soft tissue structures around the joint. The treatment is usually quite mild, and so with a little bit of rest, sometimes ice and anti-inflammatory medications, these symptoms will actually get better and resolve on their own. Some people require medication, so steroid injections locally into that area of inflammation can actually do the trick, and then usually people will be symptom-free and their symptoms don't recur. Other common symptoms in people with fibromyalgia include irritable bowel, having premenstrual symptoms and painful menstrual periods, urinary problems like interstitial cystitis or having incontinence, migraine and tension headaches, chest pain and chronic fatigue. And so oftentimes people may come in, with fibromyalgia, and they've already seen multiple different specialists for various different complaints, but everyone says, I really can't find anything wrong with you. So this is kind of a bunch of different specialists that are kind of blind, looking at examining an elephant, and they don't really know what's going on. So these are all the tender points that we check for in the office, pressing on each of these different areas that reproduce pain. And it used to be that in order to make the diagnosis, you'd have to have at least 11 out of these 18 tender points be positive. It has to be on both sides of the body, both above and below the waist. There's been a new criteria for diagnosis of fibromyalgia because now we're trying to capture more people who have it to begin early treatment. So now it doesn't even require a physical exam to really detect it. It's based on a survey of symptoms. And so it goes in 3 parts, and the first part is a widespread pain index. There's 19 different areas, some of them on both sides of the body, some of them are midline, and the patients just check off which area has been painful in the past week. And then each area counts as 1 point, and then you score it from 0 to 19. The second part is a symptom severity score, rating from 0, which is no problem, to 3, which is severe, pervasive, and continuously life-disturbing, and for 3 different aspects. So fatigue, waking, feeling unrefreshed, and cognitive symptoms. And cognitive symptoms are basically, people telling me, I feel really cloudy, I'm not having very good time like focusing, or I have poor concentration. That's cognitive. There's something kind of hazy going on there. So those are rated. And then these are the various other somatic symptoms that may also occur at the same time. So there's so many of them. But just to name a few: muscle pain, headaches, constipation, depression, nervousness, wheezing, itching, rash, loss of appetite. A lot of very nonspecific symptoms that have been seen very commonly in people with fibromyalgia. And so we kind of, if you have a few of these symptoms, then it's maybe a score of 0 to 1. If there's many symptoms, it might be a score of 2. And then if there's a lot, like 25 or more of these symptoms, then you might have a score of 3. And then you add these all up together. And then based on the widespread pain index score and the symptom score, you have to meet a certain score in order to meet number 1. And then the other 2 conditions are that the symptoms have to be present at a similar level for at least 3 months. So if it's been going on for a week because you just had the flu, that doesn't count. It has to be something that's chronic, that's not really explained by something else. And so the last thing to satisfy this criteria, you do not have a disorder that would otherwise explain the pain. For example, someone who is really newly diagnosed with a type of bone cancer, that can easily explain the pain. They wouldn't necessarily satisfy the criteria for fibromyalgia.
Isn't that hard when you have arthritis? Because when you showed that last sign, or lupus, you have a lot of those signs, so then...
Right. Yeah, so I'll repeat the question. So, isn't that going to be hard to rule out other disorders because people with rheumatoid arthritis or lupus may have a lot of those symptoms. And again, it's all about establishing that relationship with your doctor. And sometimes we can see objective things for rheumatoid arthritis because when you touch, in rheumatoid arthritis, the joints should be swollen and tender, and that's something that you can physically see. Or if lupus is active, I should be able to see a rash. The blood counts would be low. The inflammatory markers would be high. But if the lupus looks like it's being well controlled and patients are still complaining of a lot of pain and they're feeling tired, then you take a step back and you say, well, look, I don't think it's the lupus, it might be fibromyalgia, and maybe we'll try treating that instead of being too aggressive with the lupus therapy. So triggers of fibromyalgia, it's different from the types of arthritis and autoimmune diseases that we've talked about. Having an infection and different types of flu viruses, these seem to not cause fibromyalgia, but it's been very closely linked with different levels of stress, like both emotional and physical stress. So a common story would be like a patient comes in, got in a car accident about a year ago, and then since 6 months ago, I don't know what's going on, I just have pain all over, I've been having a lot of fatigue and poor sleep. For whatever reason, patients will have a heightened perception of pain, and it may be also related to the muscles being deconditioned. And there's also a role of the neurohormones being in the brain that are altered that affect the way that pain is being perceived. The cause of fibromyalgia is unknown, but fibromyalgia is something that can be managed by limiting the triggers. So we know that this isn't just something that's in your head. We actually have objective evidence that even though the muscle biopsies in people with fibromyalgia are normal, they do have altered pain perception, and they've been able to show that on MRI studies, functional MRI, where different parts of the brain in people with fibromyalgia will light up when they experience different types of stimulations by force, heat, cold, or chemicals. This is called the pain-sensing neurons that they have in the body, nociceptors. And so people who don't have fibromyalgia, those areas don't light up. So there's definitely something physiologic that's going on, and it's something to do with an increased perception and sensitivity to pain. It is important to look for other mimics and look-alike diseases, especially that can cause the same symptoms. Hypermobility syndrome, very common. Basically, when people are very flexible and their joints can move past neutral, it can cause pain because the joints are being overworked. Ankylosing spondylitis that we had about in the previous talk can also cause stiffness and pain. And in young adults, will not show up as any objective evidence of deformity because they haven't developed that yet. Can mimic fibromyalgia. Thyroid conditions, other rheumatic conditions, and then in older people, related to medications, you can have muscle weakness and other untreated medical problems. But it is very important to note that fibromyalgia can occur by itself or with other medical problems. So today we talked a lot about the Western model of medicine versus the integrative and holistic approach. And in the Western model, pain, it's difficult to objectify. It's something that's subjective to the patient's own experience. And so sometimes it's really hard to find a test. There's no test or x-ray or anything that will be able to diagnose it. There is no blood test for fibromyalgia. And so there can be a lot of frustrations on both sides of the spectrum, with patients being told that, we don't know what's wrong with you, and then the physicians are seeing there's really no objective evidence of pain. But it really isn't just in your head. They've been able to reproduce fibromyalgia and pain syndromes in normal subjects. There was a study done years ago in young military recruits. They were men in their 18, 19, 20 years old, and they were young and healthy with no medical problems. And then they would wake them up in the middle of the night around 2 or 3 a.m. and have them do drills. And then after about 2 or 3 weeks, the majority of them actually developed chronic pain. So there's something about lack of sleep and disrupting that can lead to chronic pain and having fibromyalgia symptoms. There are also medications that can help, so tricyclic antidepressants, not based on the antidepressant properties, but somehow altering the neurohormones can actually help with the symptoms.
And what are some of those drugs?
So there's, the tricyclic antidepressants like Elavil, and then there's different, not antidepressants, but gabapentin we use, Cymbalta, Effexor. So there's various different drugs that are traditionally used as antidepressants, but are actually also approved by the FDA to use to treat fibromyalgia. And also they have not been able to find increased rates of depression or severe psychopathology in fibromyalgia patients. So a lot of these people are just, normal patients walking around without any increased rates of depression, but they still have fibromyalgia. So it's not just in your head. They think that there may be some predisposing pain genes that can be associated with that. The treatment is really multidisciplinary, so more and more we're trying to involve the patient becoming empowered. So patient education is very important. There are some medications, but really the medications are not helpful if we don't try to focus on all the other aspects of their life as well. So managing stress, having good sleep hygiene, physical activity and exercise, and then cognitive behavioral therapy, where you're kind of trained to be able to manage your symptoms by the way that you think about it. So changing your perception of things can actually help the symptoms themselves. It really is important to have a trusting doctor and patient relationship. Again, there's no blood tests or x-rays that we routinely monitor, and really the expectations should be realistic because with fibromyalgia, our goal is to help the patients cope better with the condition. It's not the aim to ultimately cure it, but over time, we hope that it may improve in the functioning. Even if there is some pain, our goal isn't to eliminate the pain completely, but it's really to be able to manage the pain and have better functioning. And really, it's also, important to know that it's not something that's life-threatening. It doesn't cause permanent deformity or, like handicap, but it's something that can still significantly impact daily life. So it's very important to make sure that it's diagnosed and treated appropriately. Again, there are resources that are out there, support groups for fibromyalgia, and a lot of good information on the Arthritis Foundation website. I guess that was the end of my talk, but are there any questions? Yes.
Sometimes when I was noticing the little places that you touch, you didn't touch the head.
Right.
And I was just wondering, sometimes my hair hurts or my scalp skin hurts. Is that like a form of fibromyalgia, or is that just something that is going on specifically just with me?
Right. So the question was, sometimes certain areas hurt, like touching the scalp and the skin of the scalp really hurts. Is that fibromyalgia, or could it be some other condition? And so, the different types of pain syndromes, there are more localized pain syndromes, and then fibromyalgia is more of like a diffuse type of thing. And so I would say that in order to have that, there's a lot of other symptoms, and that's why we came up with this that's why we have this new diagnostic criteria that tries to help incorporate a bunch of different symptoms, because there are certain conditions that actually can cause scalp pain. For example, temporal arteritis or giant cell arteritis is something that specifically by itself causes scalp pain and can happen in people over the age of 50, but that causes some of the inflammation blood tests to be elevated. So that's something that needs to be ruled out. I don't think fibromyalgia by itself would just cause isolated scalp pain, and so that might be something different, but maybe along the spectrum of increased pain perception in one area of the body, for example. Yeah.
I have a question. I was under the impression, obviously I was wrong, but that fibromyalgia was more the nerve pain. That's not true, right? It's more muscular?
So the question is fibromyalgia more of a nerve pain or a muscular pain? And so it's, there's different types of nerve pains, like diabetics who have neuropathy, for example, will have nerve pain. Or if you have a pinched nerve in your back, that can lead to nerve pain going down the leg. They haven't been able to see any abnormalities on biopsies, but it's thought that perhaps it can be related to the nerves that are communicating with one another through the hormones. There's like an imbalance of the hormones that can overactivate the nerves. And so it's not exactly a nerve pain, but it is a type of pain that could be related to the neurohormones that are being communicated by the nerves. And some of the medicines that are used to treat fibromyalgia are, used in people who have nerve pain, and it seems to help, such as gabapentin or Lyrica and those sorts of meds. Yes?
Okay, so it seems like the diagnosis, this is very hard to diagnose this condition. So, do your patient have any problem with insurance companies saying that we don't cover it because you can't prove it, really?
Yeah, well, it's really not something that we aim to prove. In terms of part of the diagnosis is just to make sure that we exclude other things. Very commonly people may have hypothyroidism, and so of course you have to treat the hypothyroidism or treat the diabetes, treat the lupus first. But I usually haven't run into a problem. Are you talking about prescribing medications to treat it? Yeah, I typically just by writing down that patient has fibromyalgia and there's certain drugs that need to be tried first, but I haven't really run into a problem with people getting the medications that they need.
And do they cover like holistic or alternative?
As far as the holistic or integrative medicine approach, for all of my fibromyalgia patients, and Dr. Shibuya will also do the same, is that we really emphasize the exercise and stress management and sleep hygiene. And so all of those approaches, which do not involve medications, have been quite helpful in people who have fibromyalgia. The problem is that sometimes I'm in so much pain I can't exercise, or I just can't sleep because I'm in so much pain. So it's a vicious cycle. But once we can get that under control, oftentimes people don't need medications, and or they just need very minimal medicines to treat it.
Thank you.
You're welcome. Any more questions? I'll be available, after the talk as well and during the lunch. But yes.
So I was a little late, so I don't know if you mentioned this, but my mother had fibromyalgia, and she had an extremely sensitive nose. She would smell things that nobody else could smell. Do you see that very often with fibromyalgia, this sort of hypersensitivity in that regard?
So the question is whether fibromyalgia is related to hypersensitivity or a heightened sense of smell or other senses. And I would love to answer your question. I'll have to look that up because I haven't really encountered that myself. So I'll have to find out and maybe get back to you later.
Okay.
Yeah. Yes.
This is kind of a late question, but your earlier talk about lupus.
Yes.
I was taught years ago that lupus is either a disease of the skin or of the organs. And I know the skin is an organ, so now do they kind of bunch it all as one, or what?
Right. So yes, you're right about the skin being, probably the largest organ in the body. And so lupus has different, there's different types of lupus, like you mentioned, and there are certain types of lupus that are only confined to the skin. And for those types of lupus, there's an actual, under a biopsy, they have a certain appearance to the skin. And so for those types of lupus, they don't affect the internal organs. But the majority of lupus is actually systemic lupus, or involving multiple different organs, which include the skin. But when we talk about organ involvement, we really are focusing on internal organs that can be organ-threatening or life-threatening, such as involving the kidneys or sometimes the lungs or the heart. And so there's, you're right about the skin, and that's kind of confusing. But when we talk about organ involvement in lupus, we're really referring to the systemic type of lupus. Yeah. All right. Well, we're finishing a little bit early, but thank you so much for joining us here today, and I will be available for questions afterwards. Thank you.